And since then, so that's almost 20 years ago, there has been now hundreds of studies documenting the clinician and provider role in unequal care pretty much all along the clinical pathway, ranging from the assessment process, the kinds of questions that are asked, the signs and symptoms and the way that they're interpreted, um, symptom management, referral, and treatment recommendation. And furthermore, there's studies documenting, and I'll get into this in a little more detail, that clinician verbal and nonverbal behavior can affect the interpersonal processes of care, the quality of the encounter, which then in turn has an impact on patient adherence, self-management, and utilization, also contributing to inequities in health outcomes. So why does this occur? One of kind of my pet concerns, one of the messages that I try to convey wherever I go is that we have not been taught accurately a common understanding of the way that we as a species, as human beings, actually think, the way that our brains process information, and the ways that different parts of our brain guide what we do. So this kind of slide and this information may be fairly familiar to many of you. The System 1 and System 2 reflect the Nobel Prize winner Kahneman's discussion about the different cognitive systems we have. System 2 could also be called the conscious thinking system. It's explicit. It's what we're aware of when we say, I'm thinking about something. It's effortful, deliberative, and it's fairly slow. And the other part of it is it's very glucose intensive. It takes up a lot of glucose and it becomes exhausted fairly easily. So when we're actually focusing our conscious brain, we're using quite a lot of effort. System 1, on the other hand, tends to be very rapid. It's automatic, fairly effortless, and it's fast. That's the unconscious thinking system, implicit thinking system. There's a variety of terms for it. Some of the most widely known is unconscious. So when you actually think about the way that we operate every day, it's not that surprising that we would need a mental system that could operate without much conscious awareness. So right now, many of you may be in offices at desks, and you are right now being bombarded with millions of bits of information, but you're not paying attention to very much of it. So there's that part of your brain, right, the implicit part of your brain, System 1 thinking, that is guiding you in what is important to pay attention to. You don't have to consciously use your effortful thinking system to decide whether you should pay attention to your chair, to the coffee next to you, to the screen. Rather, that's guided, and it's guided in a way that does not deplete your energy. The part of our brain that is used to help us navigate a really complex world very, very rapidly is very well developed in the social world. But I'm going to back up now and I'm going to talk a little bit more about the unconscious thinking system because there's a couple of pieces to it that I think are really worth considering. One is that it is not random, it's motivated and guided. So some of you may have had an experience if you drive where you're driving home from work, a job you've been at for a while, or you're driving home from school or the gym or some place that you've driven home from many times. And when you leave, you're thinking, I'm going to make a stop, maybe at the store. And the next thing you know, you're home. You're in front of your building, you're in your driveway. And what's important about that is that your implicit thinking system guided your behavior while your conscious mind was occupied elsewhere. There's a couple things to bear in mind. Your implicit system didn't just drive you around randomly. It had created an association. When you drive, it's the end of the day, this is the route you take. So it doesn't just drive you somewhere or off the road. It takes you where it thinks is the most likely place that you're going to want to go given those circumstances. So it's quite adaptive and it's fairly complex. We're a social species, right? Our world, the way that we thrive, the thriving of our family members is very much dependent on how we operate in a social world, how well that we will integrate ourselves. I see a chat coming in. I'm just going to check it to make sure there's no problem. Hold on one sec. Okay, good. Just want to make sure you can hear me. It's hard to tell. So we basically thrive, or fail to thrive, depending on how well we fit in with our social world. And because we're a social species, and that's so important to us, it's so important to our children and our family members. That part of our brain is really well developed. So the social cognitive processes, the automatic system one thinking part of our brain is extremely complex and very active in the social world. One of the things that that part of our brain does for us is it tries to help us by automatically assigning people to classes or groups. So you may have, in maybe some of your other work that you've done, you may have heard that we're kind of categorization machines. One of the things that we do to simplify our world is we try to identify categories of people, categories of objects. Right? It's a very important part of the way that we evolve to make sense of the world, and it's very true in the social world. So when we meet someone, we automatically assign people very rapidly to a class or group. We may not be doing it consciously, but it is part of what happens for us. The group that we assign them to will be somewhat culture specific. It's whatever that part of our brain has learned is relevant. So we very rarely automatically categorize people by eye color, because in our culture, eye color is not seen as a very especially meaningful or relevant category. But we do automatically categorize, for example, in perceived gender and gender expression, because in our culture that has that part of our brain has been taught over and over again that that's a crucial piece of information about someone else, which has created some challenges. So maybe I won't get into that today. So the characteristics assigned to that group that we have learned about are unconsciously and automatically activated and applied. Now, one of the things that you'll see on this slide is a pretty complicated codex of all of the cognitive biases we have. And the reason I put that up there is I'm not going to go over them all, but it's kind of a fun graphic, and there's a link there you can go to it. But what that does is it points to all of the shortcuts and kinds of shortcuts that we have evolved to use in making sense of the world. Some of these shortcuts help us, some of the shortcuts hurt us, but they are there and they happen rapidly and they interact with social biases. Did I go too far? Let's see. No, okay. So many of you have learned about errors in medical decision making. And some of the work on errors in decision making does focus on social biases, but more often it focuses on other kinds of biases. So one of the ones that is most common that most people have heard of is confirmation bias. We have a variety, really 7 different ways that we automatically confirm information that we believe to be true. So what that means for implicit bias, what that means for automatic bias, is that the implicit thinking system will activate some bit of information that it has learned through repeated association about another person, about a situation. Confirmation bias, that shortcut then guides us to pay attention in a variety of ways that are consistent with that bit of information. We automatically see confirming evidence rather than pay attention to disconfirming evidence. And there are ways that we do that automatically outside of conscious awareness and ways that we do it that are quite conscious, and we may not even really be aware of what's happening. So I'll give you an example from my personal life. So when my kids are grown, but when they were younger, I was very involved. I tried to get very involved in their schooling. And I really thought that would matter, right? Parental involvement in schooling, of course, is very important because I did that. So, of course, it must be important. And I'm not really sure now. It was a while ago, but at one point, 3 really good studies came out that showed that there was really no benefit of parental involvement in schooling for child outcomes, that what it actually was an association with social class, right? And some other things that benefited kids that was correlated with parents being involved in the school. All right, so that's fine. But what I realized I did those studies to try to discredit those studies that I realized that I was heavily scrutinizing the studies for method issues because I didn't believe the conclusions. They weren't consistent with my prior beliefs. Now, the reason this is relevant is you remember the first slide where I showed you that there were thousands of studies showing racial inequities in care. What you may notice moving through your world is that the burden of proof and the level of rigor needed to create acceptable knowledge is much higher when it's something that we are not comfortable with believing. So if it's something that everyone believes, it's consistent with our cultural belief systems, there's a couple studies and we're like, okay, great, that shows it. If it's something we're not comfortable with, there will be thousands of studies before it can actually even get into any kind of understanding that this is a real thing. When I first started studying inequities in care, there were many, many studies showing that there were differences in care, and there was a lot of argument about whether that could be true because it was just extremely unpleasant. Clinicians and other providers are highly motivated to provide high quality care to all their patients, and they are genuinely mostly motivated to be egalitarian. So the fact that we might be providing care that is actually unfair is so offensive to us that it's very hard for us to believe that evidence. Part of the problem is that we have not accurately been taught the way that we think. Almost everything that we've been taught in school, almost everything that is still in medical schools, nursing schools, schools of public health, assumes that almost all of our decision making is based on conscious cognition. So the idea that about 70% of what we do is based on system one thinking, that it's automatic, doesn't fit at all. It's not that anyone said that wasn't true. It just never came up. It was an assumption. And so that's a big challenge to us in moving forward. And what I would argue is that we need to first accept that. And once we accept the fact that we actually respond to things in automatic ways, depending on the setting, we will be able to provide the environments that help us show up fully. And I'll go into that a little more. Okay, so sometimes when people talk about implicit bias, what they'll talk about is how we activate automatic attitudes or beliefs based on stereotypes. But what we may not be getting as much information about is the fact that it's guiding a lot of the way that we interact with others to confirm our stereotypes. So it affects what we notice, what we think is important about what we notice, how we interpret other people's behavior, what we remember, how we describe, and then our nonverbal behavior. So it automatically guides our attention. We will notice things that are consistent with automatically activated beliefs, and we won't notice things that are not. So when we meet someone and they are assigned to a group, we're more likely to notice things that are consistent with whatever the stereotype is than things that are not. And then we talk about it to others, thus confirming the stereotype. So here's an example of how this plays out. And this is really relevant to medical education. So in this study, this is a study from law, in the law area, but it's generalizable. Law firm partners were randomly assigned to two groups. Each of the groups were given the exact same brief. One group was told that it was written by a Black third-year associate. The other was told that it was written by a white third-year associate. When they reviewed the brief, which had errors, again, identical briefs to both groups, the lawyers, right, the law partners who were reviewing the brief and had been told that it had been written by a Black third-year associate were more likely to identify, notice, and weigh the importance of the errors than the group who were given randomly assigned groups, equivalent groups, experimental design, given the brief and told that it was a white lawyer. Now, what's really important about that is we don't usually go head to head, but what happens for us, so for me as a faculty member, is that I might be more likely, if I'm applying biases, I might be more likely to notice problems from students who are in some category that has a stereotype, a negative stereotype about academic performance, intelligence, or competence. And I would be able to justify it because I could point to the errors. The errors are there. It's just that we're more likely to notice it. And that's a key difference to bear in mind. It's not just automatic racism, it's the way that racism plays out in what we notice. And it makes it very easy for us to feel as if our decisions are fair because we can justify them. Here's another example that I enjoy this one. I like to use examples outside of healthcare, especially to start. So in this one, and some of you may be aware of this, for the longest time, auditions were open for orchestras and symphonies, and men were getting hired at much higher rates than women. And that kind of confirmed the idea that there were men were better musicians, right? And there were clearly better musicians because they were clearly doing better in the auditions. Then what happened is they started doing auditions from behind curtains so that the people who were listening couldn't see the musician. And in that case, women for a while were being hired at slightly higher rates than men. And I believe that equaled out. I believe over time now that it's become more equal because there was just a kind of a backlog of super highly qualified women who are auditioning. So it's possible, right, that the people who are conducting the auditions were consciously sexist. It's more likely that they were hearing errors, hearing issues, and noticing issues more when the musician was a woman, and hearing the extraordinary qualities and weighing them more when the musician was a man. It also guides the way that we interpret behavior, and I'm using a couple of examples here. So the picture of the newborn refers to some research that was done a while ago by Marilyn Stern, and Marilyn Stern had twins. She gave birth to twins, and they were born prematurely, but by 1 year of age, they had caught up developmentally. But what she noticed is that once people heard or knew that her children had been born prematurely, they were more likely to notice that there were or to perceive developmental issues. So she did some studies in the United States, she did studies in Israel, she did them in medical students and physicians. And what she did is she had groups observe full-term infants and toddlers. She randomly assigned them to groups in which they were told that the child had been born prematurely versus if the child had been born full term, and then asked them to rate them on a variety of categories of potential developmental delays or issues. And what happened, which you can probably guess this, the groups, the medical students and physicians who were looking at the children, same children, both groups, and had been told they were born prematurely were more likely to identify developmental delays. They were also more likely to convince others that the children had developmental delays because they could point to the evidence that they were noticing. She also replicated that with information that the mother was an alcoholic. So she had people, this is another kind of interesting thing, that if the mother was an alcoholic versus the mother wasn't, and she had people observing the child-mother interaction, and this was psychologists now, and then found that if the observers who were observing the exact same mother and child thought that the mother was an alcoholic, felt like they were able to identify, notice, and document attachment issues. The other one, so in addition to the other things I do, I'm a psychotherapist. So the other silhouette up there is from people in my field who are equally likely to be biased. And in this case, psychotherapists were shown kind of a vignette like this. And in one group, they were told that the young men were white. The other group, they were told randomly fine they were black. They thought it was white. They thought it was developmental. More likely to say, oh, that's kind of like just normal horseplay. And when they were told that what they were observing was the interaction of young black men, they were more likely to attribute it to aggression or violence. Same exact prison team case, really different interpretation. So the other thing about that system, so at the simplest level, the automatic thinking system will rapidly categorize someone we meet into one of three groups. I'm oversimplifying, but this is about it. One group is friend in group, This is someone who we think will have some common interests with ours. The kind of the more core emotional level. It's someone who you think would help your kids out if they were in trouble, who would help you out. It's the people who you trust and feel as if their well-being and your well-being are linked in some way. So there's kind of a towards feeling. Another group is a group that you see as a threat, that in some way they may represent harm, they may represent competition, they could represent threat to our self-esteem, they don't like us, they're going to be mean to us, they could represent threat to our physical well-being, but there's a threat response and a way response. And then the third one is indifference, right? They're probably not going to have much impact on us either way. And for those of you who've gone to conferences or you're in like large auditoriums with people you don't know, you'll recognize that. Like in most cases, the people around you don't seem especially like you want to get to know them and share resources, or that they're a threat. There's indifference. So since we have this really automatic classification, it affects how we feel, affect, emotion, which affects nonverbal behavior. So our conscious thinking system, when we're interacting with others and we are genuinely, consciously, and again, this is genuine, it is not fake, consciously egalitarian, non-judgmental, right? Our verbal spoken behavior, what we say, may reflect that. But our nonverbal behavior may be much more responsive to these automatically activated emotions. And what happens then is our nonverbal behavior and our verbal behavior is not the same. We're sending out different messages. So even when we're consciously progressive, egalitarian, maybe the best, clinician, provider that you've ever seen, high levels of unconscious bias can predict higher rates of blinking, less visual contact. That is then interpreted or can be interpreted in a variety of ways by the person we're interacting with. We're pretty exquisite person perceivers, going back to this point that we are extremely dependent on how well we do in the social world as a social species. We're pretty well developed. We have very rapid and automatic interpretation of other people's behavior. May or may not even be conscious. And we rely on nonverbal behavior. So the way that this can play out in healthcare, and this is like Lisa Cooper and colleagues and Penner and colleagues have done these studies. And what they looked at is they looked to see if the level of automatic or implicit unconscious bias towards Black versus white is in the implicit association test. I won't have time to get into that too much. What they found is that physicians who are higher in implicit bias, negative biases, had an impact on the encounter that was interesting. When Black patients interacted with physicians with high implicit bias, but low explicit bias, genuinely progressive, genuinely well-meaning, genuinely fair and egalitarian, they still had a lower rate of confidence, respect for, and trust in the advice of that medical professional, which then in turn predicted lower levels of adherence. Now, some of that might be, and it was actually higher when there was high implicit or unconscious, system one bias, but also low conscious bias, because the disconnect between the verbal and the nonverbal behavior is pretty disconcerting. And so the interpretation was a bit of lower trust. Okay, I'm going to just go through these. I put these up here because sometimes there's a lot of questions about, is worthy evidence. So there are some studies. Actually, I could probably update those, and they'll be in the slides if you want them. So why is it that we can and do care deeply about providing equal care and still potentially perpetuate discriminatory care? Social attitudes and biases are self-propagating and self-reinforcing. So this is like a juxtaposition of pictures that people have often seen before. So maybe you've seen these before. This is during Hurricane Katrina, and at the top you see this young man descriptively wading through the water. Poor guy, chest deep, presents his mail. And which is actually a function, may or may not be, right? But anyway, I digress. So the Associated Press reporter took this picture and reported that there's a young man walking through chest-deep floodwater after looting a grocery store in New Orleans. Right? That was the interpretation. And the bottom, what you see is you see a couple of a female, male presenting as white, and the interpretation is two residents wade through chest-deep water after finding bread and soda. And to a certain extent, there's like two things that go on here, and I do want to point this out. And one is a white uplift, like the benefit of the doubt that we get as whites often, or we give to our in group, that we give people in our in group the benefit of the doubt often. So that's partially that uplift, which is lovely. We just would like everyone to have it, right? But there's a couple things there. Now, the reporters obviously were not looking at the two pictures side by side, and their interpretation of the behavior was based on some automatic assumptions. I doubt that there was a conscious intent to kind of perpetrate racial ideology. We very rarely see that, but the problem is that, and there's many, many studies of media presentation, and the problem is that our unconscious thinking system, that part of the brain that is just looking for information through associations, it's not moral, it's just trying to make sense of the world, we'll see this over and over again, the same behavior interpreted differently. And the connection here, for example, between this poor person who is already has enough trouble, who's being interpreted as having looted a store. So the way that we do this ourselves is through language. It can be fairly subtle. So, for example, in reporting on an intake, we might be more likely to say, if it's a Black patient, that they deny a history of substance abuse, right? So, okay, fine. For a white patient, no history of substance abuse, negative for history of substance abuse. And this, again, as we read this over and over and over again in the medical record, in the way we talk about it, it reflects these automatic biases and they reinforces the bias. So given that we're surrounded by this, and given that we have this sort of automatic way of interacting with the world, what do? We know a lot about when we are most likely to activate negative biases and when we are least likely. And we can apply that if we choose to our organizational systems and to ourselves. So the first thing that's really important is understanding the conditions that precipitate bias. Biases aren't neutral in a way, they serve a purpose. So going back to this unconscious thinking system, and if we have, cognitive psychologists, just bear with me, I know unconscious isn't exactly right, but it's often referred to that way. The automatic thinking system, the type 1 system, that system is there to help us. It wants to respond to the world rapidly in a way that will be to our advantage. So it actually activates things in a way that's context specific, that has to do with, if in that situation, is this information helpful? But it also guides our decisions, whether we're aware of it or not, about when to use resources. And here's a challenge for us, right? So, there's a group right there at your organization that's doing amazing work in this topic. I think Implicit Bias Research Group, I probably have it. I'm probably not calling it the right thing. But one of the challenges that we have, so I'll be saying this in a minute, is that using perspective taking and empathy, right? And actually the really exciting work that they're doing on looking at ACT, which is a psychotherapeutic approach that might actually be extremely helpful in helping us prevent implicit biases in our own behavior. So it's very cool work. But one of the challenges we have is that our automatic decisions about whether to use the resources to engage in perspective taking, which actually is effortful, will be driven by the unconscious thinking system. So part of what's going on here is that system is saying, okay, do we have the resources to actually really think about others in an empathic, connected way? Or do we want to save those resources, those cognitive resources, that energy? So do we have the resources? And often, if you think about COVID-19 and the depletion that's occurring for on-the-ground clinicians and other providers, it's depleting resources that we might be using to interrupt bias. But also, are we motivated to use the resources? And here's another little tricky thing here. We're more likely to want to use resources for people we identify as being part of our in-group. The other thing, this is important to really be thinking about when we're thinking about ourselves, thinking about the way we interact with each other, and thinking about our organizational climate and systems. They also serve core needs. So clearly, the automatic thinking system is serving a need for survival, right? But it also serves needs for self esteem. It's, we're pretty, we're very motivated to preserve our own sense of ourselves. And some of what's activated will have to do with how we're feeling about ourselves and if whether what's activated will help us. So, for example, there was a study in which a white patient, a randomized study where a white patient was interacting with a black physician. And when things went fine, the patient was more likely to activate a fairly positive stereotype about physicians. Right? When there was something in the encounter that the white patient found undermining or uncomfortable or challenging, they were more likely to activate a negative racial stereotype. Again, this isn't as if people are consciously like sorting through their stereotypes. This is an automatic responsive or unconscious thinking system, which is seeking to help us. So any kind of threat, loss of power, loss of resources will exacerbate stereotypes and increase bias. So any time that we increase our sense of threat for any reason, we're at higher risk of expressing automatic and negative biases. Burnout has also been shown to increase implicit racial bias, and this is some studies that other people have done and our group has done also. This is because burnout increases reduces any kind of resources, increases negative affect. So what do we do about this? We need to create the conditions that increase our capacity for equal care, that will bring out the best in us, because we as a species are capable of glorious, fabulous altruism and really extremely inspiring and just action. So what will bring out the best of us? What will allow us to have the most positive intergroup interactions? And what allows us to behave in ways consistent with our highest values? So there is the handout has a little bit more on this, and some of this has to do with organizational factors, right? So obviously, this may be something that you have jumped right ahead to, or you may have seen obvious in what I've said, but anything that depletes our conscious resources makes us more likely to rely on automatic biases. So if we're tired, we're pressed for time, we're anxious, we're cognitively busy, we are going to be relying on system one thinking to guide us, because we don't have enough energy to really engage that conscious thinking system and interact with someone and really focus on them as an individual. We're going to be relying on whatever we can come up with from that system one. And this is really important when we think about what's going on with COVID-19. So COVID-19 is what I would call the demands of COVID-19, the challenges in our response, and the systems that are inadequate to respond in a way that is protective of clinicians, providers, and patients are biasogenic conditions. They're creating the conditions on us that make us most likely to be relying on automatic biases and least likely to be able to notice, identify, and interrupt. Protective factors include stable routines, minimal disruption, clear roles, sufficient resources, and healthy employment policies. So one of the issues or problems that we have is we're always trying to improve our systems. And that's not really a problem, it's a good thing. Let me rephrase that. One of the glorious things about it is we're always trying to improve our systems. But what we don't often do when we're thinking about changing our systems of care, our medical records, reminders, is that anything new requires cognitive effort that we then can't use to really focus in and individuate our patient, to really focus on the patient as an individual. So any kind of quality improvement changes might need to be balanced against the stresses it's putting on clinicians and providers to use their conscious thinking system to do something new. So if you think about going to work when you know exactly what to expect, you know exactly how to test, you know what to expect from each other, you know what the systems are, that really does free you up. Now there's a change in that, ideally to improve the processes, that's going to take some of your energy. It's just a matter of thinking it through a little bit to make sure that the change is worth it. And I also think maybe the frequency of change is, my personal opinion, might not be as carefully thought out in terms of its impact on quality of care. The other thing we know is that our organizational climates matter, and they matter a lot. So the organizational climate for equity, inclusion, and diversity has been shown over and over to affect every aspect of organizational functioning, including things like financial performance and quality of safety of patient care. So we are more likely to provide equal care, and actually our organizations function better on every category when the organizational environment meets our DP needs for self-esteem and for belonging. Psychologically safe organizations that allow for a constructive approach to the human characteristic of learning through mistakes will make us much less likely to have unequal care and to be biased in the way that we interact with each other. I mentioned this now, but I will say this because I think this is really important. So there's research that shows that when some of you may be familiar with stereotypes, Brett. I'm not going to get into it too much, but there's some research that shows that I'm white. You saw my thing. So when white people feel concerned that they may be perceived as being racist, right, that they have an anxiety that someone's going to see them as racist, then actually the reaction isn't ideal. You tend to to have more distance from people of color. It may actually even increase feelings of bias and hostility. Now, so that has something to say about our anti-racism training. So if we're doing anti-racism training and we're actually triggering all that negative response, we could be doing harm. Now, here's the beautiful thing, though. When it's done in the context in which there's an expectation of psychological safety, where there's a growth and learning mindset, where mistakes are to be expected and people are expected to learn from their interactions versus to perform perfectly, it seems to eliminate that automatic negative reaction to, let's say, anti-racism training. So a growth and learning mindset to intergroup interactions, where the expectation is that people are going to be open to learning, not that they're going to be perfect, is extremely important for a positive climate and for the kinds of approaches we're using. So the thing that we're going for here is that, for example, again, as a white person, that the people I work with, right, so white, cisgender seeing, hetero seeing, all of those things that kind of give me an uplift. That people who are experiencing a very different world or walking in a different world, a person of color, is a person who presents as transgender, someone who's experiencing something really different than I am, that I can't see no matter how well intended I am and no matter how deeply I care about it, and I do, that they can be safe to tell me when I've said or done something hurtful. And I can hear it without sinking into a puddle of shame and defensiveness. So that's the goal we're going for at your organization, is to make it safe for people to tell, to say that hurt, you're missing something, or that curricula is really portraying people of color, or why is it that all these books show everybody with an STD as a person of color, which your books may not anymore, but that's been a challenge for a lot of our medical books. And that the people who are hearing it, who may not have noticed it because they're walking in a different world, can be like, thank you for telling me. So that's our goal, and that's what's going to be necessary. Racism is malleable. We can learn to be unbiased. Okay, individual strategies that you can use. So there's some mind hacks, right? Some of this is automatic. We're tired. I just mentioned that being tired makes it harder to overcome it. But there's a few different things that we can do. We do give a bit of an uplift to anybody who's in our in-group. And the interesting thing about us as a species is we're pretty malleable on who we think is in our in-group. Some of you may be aware of it, but we can take any given class, divide them into two groups, right? Give the red group a red shirt and the blue group a blue shirt and have them compete on something. And the research shows that by the end of the class, the people in the blue group will genuinely kind of think the people in the blue group are just kind of better people. And the people in the red group will think that people in the red group are better people. So it's kind of bad, but it's also good, meaning that we can create a situation situation in which we are seeing ourselves, each other, and our patients as part of the same in-group. Many of you have gotten training in partnership building skills. It's very similar to some of the work on creating what like social psychologists have called a common means of identity. So when we experience an encounter with a patient and we're thinking about them as being on the same team with common goals, the research is showing, a couple of studies have shown that we're less likely to express bias. So we can use mind hacks like the word we, us, versus I, you. Just those terms kind of make our brain think this person is part of our in-group. And that's a fairly effortless way to avoid expressing bias or experiencing a bias in our response. So focus on common goals. Think of yourself as on the same team. You may also just try to look for a couple of things that you have in common, whatever that might be. Use inclusive language. The second thing that I mentioned, and there's a very robust literature on this, which is that empathy, right, connecting with others, makes them part of our in-group and can prevent automatic biases. There's a couple of different kinds of empathy. The cognitive component of empathy is perspective taking. It's our ability to see ourselves in the other person's shoes, look at things as if we're looking at them through their eyes. So there's quite a lot of research that's just taking a moment to imagine yourself in the other person's shoes, try to see things through their eyes, will derail bias. It's a bias preventive strategy in that interaction with that person. One of the things that's really important about, let me go back to this a second, about perspective taking is that it's a skill. Some people are already really good at it. Other people need to learn it. It is a very learnable skill. And so the trick there is to practice it and practice it with people you're close with and check your perspectives. So, for example, if I'm going to engage in perspective taking with a patient or someone new I've met, the thing to do is to try to imagine myself in their shoes, but check it out and say, I'm just thinking about what this might be like for you. And I'm wondering, if I was you, I might be experiencing it this way. And I'm wondering if that's what you're thinking or feeling. And let them correct it. It's an important step, especially as we're working with people who are walking in really different worlds than we are. So if you take nothing away from this other than this, one of the main things we can do to be true to our values is to take care of ourselves and to have compassion for ourselves. Some of the things that exacerbate bias the most is when we are depleted, when we are having negative emotions, when we're feeling angry towards ourselves, because that system is going to try to help us feel better about ourselves. And often that system will automatically do that through something called downward social comparison, which is thinking about other people negatively. This is not necessarily, a conscious choice, but it is an automatically activated approach. So positive emotions have been shown to inhibit the activation of unconscious stereotypes and prejudices, and they lead to more inclusive social categories. They make us see ourselves as part of a larger group. I'm happy everybody's in my in-group. Conversely, negative emotions like anger and disgust exacerbate implicit bias. And that's true even when the source of the negative emotion has nothing to do with the actual patient or the social group involved. Something can make you angry or disgusted that's outside the exam room, but it may make you more likely then with that negative emotion to activate implicit bias or automatic bias with the patient in the room. So one strategy that is really important is emotion shifting strategies. So there's a few things that are really helpful in allowing ourselves to show up fully. Strategies that allow us to shift our emotions and negative emotions to neutral or positive. There's more and more research showing that mindfulness practice helps us stay present in our conscious intention and much less likely to be driven to behave or see others in a way that's emerging from system one, implicit unconscious system, that is not consistent with our values. So if you take nothing from this other, then this point, learn emotion shifting, learn strategies to help you reduce anxiety and stress. If you have a lot of negative self thought or self talk, find ways to work that through to change that to more self acceptance and self compassion. And I know that that can sound, I don't know what the word is for that, but I know that that maybe isn't necessarily consistent with the sort of dominant values of people who are learning to be physicians or are physicians. But it's hard to argue with the evidence on this, that the evidence is, this is what allows us to be much better caretakers for others. If mindfulness, learning mindfulness is a fabulous strategy. Practicing mindfulness is something that is got benefits in a variety of ways, including all kinds of performance as well. Okay, a couple of little strategies that you can use. Check for double standards. So if you're interacting with someone, you're having a negative reaction to them, take a minute and imagine how you would react, feel, decide, or behave if someone else in a different social category acted in the same way. So one of the things that we were just doing in an intervention with nurses, but also with medical residents, is that we tend to have a bit of an automatic bias to think that women's symptoms might be psychogenic. Or overreacting. There's this kind of like stereotype that women make too much of their symptoms. So one of the ideas then would be is if a woman is complaining, comes to you and is complaining, let's say, of abdominal pain or chest pain, and your first temptation might be because of this automatic bias, even though you're a fabulously good and non-sexist person, genuinely, okay, might be to kind of wonder if they might be overreacting, making too much of it, or maybe it's psychogenic, is to imagine for a moment if it was a man in the same instance. Would you have the same reaction? So checking for double standards can help us. It's a check on ourselves. And then it allows us to test our hypotheses about this patient or this person a little bit more rigorously and rationally. Don't suppress stereotypes. It is tempting. We don't like them. They make us uncomfortable. So if we become aware of a negative stereotype and negative bias, it's not consistent with our values, we dislike it, and we can tend to suppress it. That actually doesn't work. It can backfire. So the thing to do is notice it and let it go. Anytime we try to suppress stereotypes, there's some evidence that we're putting effort into that takes our energy, and later it can cause a rebound effect where we actually are activating more negative stereotypes. Cultivating something called positive attribution bias is an extremely helpful strategy in terms of pretty much every type of encounter with people who may be different from us or come from a different world, a different point of view, and a different culture. We do tend to have an automatic discomfort with things that are different. So you may be going through a variety, or you may have gone through a variety of interventions or training or programs that focuses on cultural competence. The automatic thinking system does have a pretty negative reaction to people who have very different ways of believing and behaving, and that can cause problems with us. So one strategy that can help is to notice the reasons you think people are doing things and assume positive intent. When I was in Minnesota for quite a while, and there are a few immigrant populations, but two major immigrant populations were Somali and Hmong. And they have very, very different ways of behaving in the healthcare. So culturally, Somali patients are more likely to be assertive, to feel as if they should, that they need to really advocate for themselves and ask fairly actively for what they need and ask questions. And maybe express their feelings of mistrust, which is culturally consistent of that group. I can only speak to the group that came to Minnesota. It's a big country. There might be a few cultural belief systems going on there. The Hmong patients, on the other hand, tend to be quite quiet and deferential. And one of the challenges was that some of the staff were really having negative reactions to the Somali patients because Minnesota is a pretty polite state. I moved there from New York. I had my own problem. And so they were making some attributions about these patients and their intentions. They were interpreting it as disrespect, when really it was just culturally consistent. So one strategy is assume the best intentions An interesting thing about us is we, as a species, always want to come up with a reason why everyone else is doing something. We can't help ourselves. We're wrong a lot, and positive attribution bias, at least if it's wrong, is less likely to cause harm. There's a lot of research showing that we will do a lot to discount information that we don't like. We have an automatic preference for information that fits in with the idea of a just world. It's pretty scary to think the world might be random, unfair, and unjust, and that harmful things that happen to others that could happen to anyone. And so we do tend to have an automatic desire to believe that when discriminatory things happen to others, that it's not actually discrimination, that there must be some other explanation. And that's okay, it's automatic. The trick is to notice it when it's happening. You know, again, with self compassion, the goal is to notice these automatic responses, to not let them affect your behavior, but to accept them and let them go. So many studies have shown that we're biased in the way we evaluate evidence of discrimination or differential treatment. And this is whether there's an individual telling us about it or whether we're looking at thousands of studies documenting it. So the standard of rigor or evidence for studies of racism tend to be higher than studies of things that we're much more comfortable with. I like this cartoon. My desire to be well informed is currently at odds with my desire to remain sane. So evaluate your skepticism. Skepticism is good, right? We do want to be skeptical. We want to be really sort of intelligent consumers of information. So I'm not at all arguing against skepticism. I'm a big fan of skepticism in the scientific world. But what I am saying is be aware that you may be more skeptical of some information than others because of these automatic responses. I like this cartoon also. It's one of my favorites. So we do discount information that's not consistent with our beliefs. And I think sometimes this is on a screen and I read it, but I'm guessing all of you have it on your computer screen and you can read this yourself. So we're kind of at the end of the hour, so I want to mention a few key points, and then what I really am hoping to do is answer questions, or I can elaborate on something if you want. I especially would like the people who have deep expertise in this area. If you notice that there was something that you felt because I'm going rapidly was unclear, or maybe could have been misinterpreted, if you've taken a moment to put that in the chat room so I can fix that. So the key point here is there are widespread and deep inequalities in healthcare, and we, as clinicians and providers, are perpetuating inequities in care. The factors that cause these are actually at the root of all threats to safety and quality because it is the same same characteristics or limitations in the way that we think, in the way we process information and make decisions that tend to be at the root of all errors. So the bad news for us is that we do have several known social and decision-making biases that we evolved, our brains evolved in a way that was presumably adaptive. I'm going to assume it was adaptive when we were in small groups as a species of people who were very much like us, but is considerably less adaptive in our current world. For example, the way that we categorize people automatically into in-group versus out-group, and remember in-group are people who have common interests, tends to be that part of our brain does it by appearance. But in reality, if you think a moment, the people who have common interests with us may not look very much like us at all. So it's a pretty obsolete strategy, but it's still in play. We evolved that way. Under the right conditions, we can overcome the biases. There are conditions that allow us to show up fully in our genuinely conscious, egalitarian selves in a way that's consistent with our values. But we can't just do it based on willpower because we have too much going on that's automatic in dealing with the social world. So we have to use specific strategies as individuals, and we have to do our best to create the environment that will allow us to show up fully and will be least likely to be what I would call biasogenic. So all of our strategies and interventions have to be responsive to what we are actually like as humans, not what we want to be like. We would like to be fully in control and have our conscious motives guide our behavior. There is the evidence from every single field that studies behavior in the mind is overwhelmingly saying that is not the case. So we need to be thinking a lot about what is the evidence and how do we create the environment and the practices and the strategies that protect us and our patients from biases. The last thing I want to mention is that the current pandemic is creating conditions that are highly likely to exacerbate bias, as well as the impact of bias on patient outcomes. Recently, you may all have many stories yourself or have heard them. Part of what's important is that this isn't just playing out with patients who maybe should be tested or having symptoms. It's playing out extensively in patients who have any kind of care need that has nothing to do with COVID-19, because the structures and systems that are in place are, at this point, the rules are being bent. And when the rules are being bent and we're exhausted, that's when we're most likely to show group bias. So there are people who are not necessarily who are calling up, and they may not be asked to come into the emergency room. Their symptoms may be discounted. I've heard of in the last 2 weeks, people told me about 2 deaths of people who were kept calling up and were told not to come in. And then it may also be in terms of which patients get extra help. So there's other stories where some people their prescriptions are being used over the phone, where others are told they need to come in. Same conditions, same issues, same symptoms, but just a different kind of automatic response based on this emotional affect. How much do we want to help this person automatically? Now, again, what I would say is it's not that anybody doing triage, for example, it's not that they're consciously saying, oh, I care about you and I don't care about you. It's kind of an automatic response in terms of the way that they're evaluating what they're hearing. So one of the pieces that I think is so important for all of us is we need to take really good care of ourselves. And we need to be thinking a little bit more consciously about how the way these things play out may be affecting what we're noticing about patients, and what we're asking our patients, how we're weighing what we're hearing, how we're interpreting what they say, and perhaps our nonverbal behavior as well. So I'm going to end there and see if there are questions.
Hello, this is Jennifer Doherty. Thank you, Dr. Vanren. That was a wonderful talk. We do have questions. And to kick off our Q&A, since you just chatted about the pandemic, we had a question come in asking about that. So, can you speak to the racial disparities we are seeing with COVID-19, and how can these disparities be mitigated?
There's so many. Basically, what's going on is all of the structural inequities are kind of coming home to roost in major ways. Some of them have to do with things that are like structural access issues, right? So if you think about the fact that, like, let's talk about black-white, right? Because it's not the only one. There's also major issues for patients who are obese, who are stigmatized, but the black-white ones are dramatic and devastating. So if you think about the fact that we have had increasing residential segregation, and that the increasing residential segregation is increasing the proportion of Black families who are in inner cities, in neighborhoods, and the fact that there's more white flight outside of cities, you see that the result there, of course, is crowding, right? So there's crowding and there's going to be transmission. And the policy response and the advice for people of color and also people who are socioeconomically disadvantaged is, in my mind, in my opinion, insulting. So when you say things like, oh, if someone has got symptoms, isolate them in another room or keep a distance, that presumes you have a large enough house. So it's not just that we have these conditions that differentially disadvantage some groups and advantage others. It's also that our responses are acting as if that's not the case, which seems to me to be fairly chilling. Right? So I find that fairly, I personally find that like deeply chilling. And it's not very helpful because by ignoring the realities, it's failing to, it kind of lets us off the hook for coming up with mitigation and helpful solutions for people who perhaps are very crowded, who may not have excellent access to healthcare, may have access to healthcare organizations that themselves are overcrowded. So that's one piece. There's some like structural pieces that we that I would say that the situation is just bringing them into light in a different way. That they have been there. They have. It's not like they are surprising, but that the situation is really problematic. So the answer to the structural thing would be to think a little bit more about if you have low-income people or people who maybe aren't low-income but are residentially segregated and crowded, what would the policy response to provide them with the resources they need to for social distancing and to prevent transmission? What are the policy responses that would allow for sufficient resources to the healthcare facilities that they may have access to? So those are like policy level resource allocation questions that they may be being asked, but no one's really taking them very seriously as something to respond to. That's my opinion now, right? So I have opinions, obviously. The other issue, though, would be the way that once someone enters the healthcare system, how they're being responded to. And this is the kind of thing that we just talked about. And one of the big challenges we have in a crisis like this is we're moving fast and we're tired. One of the reasons mindfulness works is it slows us down. It makes us present. It makes us more self-aware. So the interesting thing about emotional regulation and mindfulness is that we tend to, myself included, feel like we don't have time for it, right? We're too stressed. We've got too much going on. How can I take a moment and do some deep abdominal breathing? How can I take a moment and put myself in this other person's shoes? In reality, the evidence is that it doesn't take that much time and it conserves our resources. So these would be some of the pieces that I would say. I would also say we need to be noticing and supporting each other. So the way that racial stereotypes actually and other kinds of stigmatizing conditions will play out will be that we will notice things that are consistent with stereotypes, right? So we may be more likely to discount symptoms for some people other than others. So then the question we need to ask ourselves is, if I was hearing this from someone really different, would I be responding really differently? But even more than that, we need to find ways to help each other with it. So you would need to find a way to help me. Let's say I'm responding to a crisis call from someone who is, so in the mental health world, it's really terrible right now because people are being isolated in extremely problematic home situations. And I'm responding to a crisis call from someone. If I'm responding in a way you notice it and you're wondering if maybe I'm kind of expressing some like assumptions or biases, you need people to ask me about it and say, if that person was, lived in farm country outside of Oregon in a big house and they were telling you that, would you respond differently? Or for some of us, if that person was low income, would you feel like they needed you more? It could be the opposite. It can go a lot of different ways. We need to create the kind of environment where we can welcome helping each other with that. The only way to do that is to recognize this is part of our human heritage, that we need help with it. We're not always going to be doing that. So the mitigation question, I don't have all the answers to that, right? So I'm a social psychologist. I can tell you a lot about the way that we interact with others and what we can be doing once people come to us as healthcare providers. The larger structural factors, what we can notice is the same things playing out at the policy level. What kind of conversations are occurring in our politicians? Why is it okay with us? A piece that I'm finding really interesting is in the conversations about rationing of scarce resources. So if we're thinking of there's conversations about algorithms, for example, for who gets ventilators, and I don't know how much you've been hit with that there, or if that's not especially an issue for you. But like if there's too many people, we don't have enough ventilators, and we're anticipating that, people are coming up with a variety of algorithms for decision making, and sometimes those algorithms have to do with risk and benefit, right? Who's likely to benefit, who's not doing as well. What you'll notice if you pay attention is some predictors of poor outcomes go in those algorithms and others don't. Now, I'm going to say something, and I want to say first, I don't think this should be in there. I am not suggesting that I think that what I'm about to say should be in an algorithm. It should not. I think it would be terrible. But one of the predictors of poor outcomes is male gender, right? But we would never put that in an algorithm. We would never say, okay, negative 2 points as a man, you don't get the ventilator, or that counts against you. Because we just don't think that way. We're much more likely to focus on things that we're more comfortable with. So some of the question then is, why are some characteristics that make somebody have worse outcomes, perhaps because they've already been socially disadvantaged, acceptable to us? And a lot of that, again, it's not conscious. Like, it's not a conscious evil intent or a conscious undervaluing. It's an automatic response to something that seems consistent with everything that's gone before. Boy, I wish I could see your faces. I'd like to know if this is making sense. So I think what we need to do is just be thinking, asking questions like, what goes into our algorithms? What's going into our decisions? If it's really all about clean risk, well, should it be about every factor that is associated with risk and benefit? And why are some factors okay and other factors not? If we have people doing triage, do we know what decision rules they're using? How are they deciding if someone's symptoms are bad enough to bring them in again into the emergency room or to tell them to go away? What are people doing? And we need to be helping each other think that through a little more, and supporting each other. And the last thing I would want to do is put more misery or pressure or make someone who is having the horrible job of doing triage feel as if they're being under scrutiny or criticized. But what I would like is for that person to be supported in a more careful way of approaching decision making about who gets seen, who doesn't, who gets care, who gets help, and who doesn't.
All right, thank you. We do have a handful of questions here tied to learning and growth mindset. One of those questions is, the learning that leads to implicit bias seemed more implicit, more subconscious, whereas the learning that could lead to be unbiased would be more explicit and conscious. Is this type of unlearning as effective?
Could you repeat that? I'm sorry.
Yeah, not a problem.
Yes, go ahead.
The learning that led to implicit bias seems to be more implicit, more subconscious, whereas the learning that could lead to be unbiased will be more explicit and conscious. Is that type of unlearning as effective?
Okay, so I don't know that I am not when I make suggestions about ways to prevent implicit bias from affecting our behavior, I usually don't talk about changing implicit biases. What I talk about is interrupting the impact of automatic bias on behavior. So what you'll notice in all those evidence-based strategies, none of them were like, okay, this is going to actually change your automatic associations with one group over another. It can be done. It's just really, really difficult and not especially realistic without massive changes. So for me, what most of the evidence would suggest isn't that there's always caveats to this, right? It's not like people haven't changed implicit bias, and it's not like there isn't variation in how much people have bias towards different groups. There are about 20% of whites don't show negative biases in the United States, don't show negative biases towards African Americans. At least 60 to 80 who do, right? Most of us. So the issue there isn't unlearning bias. It's in preventing automatic belief systems that aren't consistent with our true values and conscious beliefs from affecting our behavior. We do have a lot of automatic responses, right? In a lot of different ways. I don't know if anybody has ever felt like hitting someone or breaking something, or we do, or eating something that we don't eat. We have a lot of automatic responses, right? But we don't necessarily let them affect our behavior. We find ways to interrupt them. I think one of the biggest concerns that I have had about much of what I've seen in implicit bias training is the idea that awareness of implicit bias is enough, that if we know we have it, we can consciously interrupt it. It's true that we can interrupt it, but it's not true that just knowing about it is going to do it. That would be that statement, that we can use like a conscious decision to not have implicit bias. And so what you'll notice is that what the recommendations that we're making, that the evidence actually supports, is things that, one, as I said, we don't always activate the negative bias. Sometimes it's positive, right? So how do we create a situation where we're much less likely to activate a negative bias? And then two, given that we may have automatic biases against a group, how do we make sure that in any individual or small group of people from that group, how do we make sure that we're not applying that? We're just dealing with that person as an individual. Perspective taking, creating a common in-group identity, emotional regulation. So that's really what the evidence supports. There's a couple studies that show that for a short period of time, counter-stereotypic imagery can change automatic biases, right? So if you have enough images, actually, the studies are actually kind of odd. They are positive images of admired African Americans and negative images of criminal whites. Those exposures will, for at least a while, and we're not really sure how long, but maybe not very long, correct sort of pro-white negative Black biases. The challenge we have, of course, is that then we go back out into the outer world. The one thing I would say, though, about organizations is I think organizations can do a lot to cue different, can kind of create an environment that cues different beliefs through the imagery. So what imagery do you have around you? Can you change the imagery up? It can't hurt to make sure you have a lot more positive images of, healthy and active people with obesity, right? Extremely successful and likable African Americans. So it can't hurt to have these images around to counter the other images, but they're probably not going to be enough without other strategies.
All right.
Somebody asked me a question about explicit. I feel like I must have misspoken because I did get a question that came in privately that made me think I misspoke. Oh, I know what it was. Okay. Yeah. So I'm sorry. I think I misspoke or wasn't clear. So there's a couple of studies showing that patient mistrust was highest when someone with high in implicit bias and low on explicit because of the disconnect, right? What I would say is that in those cases, that when we are showing the nonverbal impact of an automatic emotional response, right? It's because we are responding to the person as an exemplar of the group. So what we do know is that on average, white Americans may be more likely to respond with threat to, or I don't know why I came to the country, white individuals are more likely to respond with threat to Black individuals, especially Black men, right? So if we interact with someone in our primary way of interacting with them as a Black man, then our nonverbal behavior may not be consistent with warmth. But if we connect with that person, either through creating the partnership, the common in-group identity, being on the same team, doing the perspective taking, seeing things through their eyes, then we're more likely, let's say this person's John, we're more likely to respond to them as John. And then that can attenuate the nonverbal behavior. That can make our nonverbal behavior be consistent with our conscious egalitarian beliefs and motives towards John. I think the point being is we have to take action, meaning we can't just assume that our conscious egalitarian beliefs are enough. We also have to know that our patients are coming in with a lot of experiences of discrimination. They don't necessarily know that we are non-discriminatory. In fact, there's probably a lot of reason to be vigilant. And so if we assume that they're going to know that they're going to give us the benefit of the doubt, we might actually miss an opportunity to create a really good connection with another human being.
All right, thank you for that response. I've had a request from the audience. If you'd be willing, they would love to see you as you're answering the questions.
Oh, yeah. Sorry, I forgot to turn the cam back on. Give me a second. Oh, I took my jacket off, so I'm putting it back on first. Because you know we're gender biased, and all if I have a jacket on, you'll lose all respect for me. Okay. Am I on cam?
Wonderful, you are.
You're on cam, but just real quick, if I can interject, since we're close to 6:30 here, are you okay staying on a little bit longer for some additional questions?
Sure.
Okay, and then I want to, if anyone needs to leave at this time, I want to be respectful of your time since we said we'd end at 6:30. But for those of you who would like to stay on and ask questions, it sounds like Dr. Venrin is being very generous with her time and staying just a little bit longer. So thank you.
I don't have to catch a ride home. That's the beauty of this.
All right. Continuing on the track of learning and growth mindset, we had a question come in regarding creating a growth mindset / learning environment. How do you suggest we create a balance between creating an environment that allows people to make mistakes and question / argue with what you're teaching, with not enabling those people from elaborating with prejudiced language that could trigger / weigh on minorities in the audience? And there's a part 2 to that one as well. So
yeah, that's a really good question. So a growth and learning mindset isn't one that that is encouraging people to say hurtful things. And so sometimes, it's hard because it depends on the specific instance. Sometimes it's like a question posing thing. One of the more recent examples I had is where I was teaching a medical school class, and after I did my talk, a couple of the students of color talked about some of the, felt like they wanted to share a couple of the experiences they had had. And another student there who, like a tall white male student was, outraged that they'd had those experiences, but then kept saying how that like they would never let that happen. They would not speak up. Why didn't these people speak up? And kind of actually unintentionally, I'm sure, made it seem as if somehow the students of color just hadn't done the right thing. Like if only they were brave enough, it would be fine, and that this person wouldn't. And what I noticed, like a couple of things, and part of it is, if you think about what might be going on for that young man, it's painful, right? So struggling with the idea that this is really, real, needing to distance, it can't happen to me, like just world kind of thing. But unfortunately, it was harmful, right? So here we have this, like you can see what this person was struggling with. You can also see that in their world, speaking up and complaining is usually met with success, right? So there's some people who, if they, complain and speak up and are treated unjustly, they feel very empowered to speak out, and they didn't expect to be harmed by it. But you have other people who speaking out might actually cause them great harm, and that's walking in a different world. It's a disconnecting and walking in a different world. So in that case, what I did, and I'm not saying I'm not all saying this is great, and I wasn't able to study the outcome. But what I did is I invited other people to speculate on what might have happened Like, what are some alternative things that could happen, or why might it be that some people won't want to speak out, or what are some experiences they've had? And that's when you started hearing people's firsthand stories, right? About either white people knowing these stories. Again, I'm kind of using this color language. Like saying, okay, like I've seen this happen. Sometimes it was people from other groups who said, yeah, if I ever said that, I would be laughed out of it. I wouldn't have any opportunities. And then, there's a lot of groups who've experienced marginalization and they can share the stories. So, but I tried to invite them to do it in a way that was respectful of the speaker, not being like, you're coming from such an entitled and privileged place you can't possibly understand. I mean, sometimes it's tempting, right? But that's not helpful, and it's not going to help that person learn, and it's going to actually alienate many others who are really struggling with this fact that the world they're in isn't the same world, isn't shared by others. It's pretty painful. It's a painful piece of information. The other thing, though, is that there's misinformation, right? So whoever wrote that, can you give me an example, like write in an example really quickly of the situation that you faced with that? And maybe I can respond to that. I don't know, Jennifer, is that, or Nicole, is that going to work?
It should work. Like I said, there is a part 2 to that question, so maybe the part 2 might help elaborate on things. So the part 2 to that question is, at which point are we creating a better environment for people who have yet to unlearn biased thinking than for people who suffer from that biased thinking?
Oh, accountability. Yeah, gotcha. I understand what you're saying. So how do you create accountability, right? So some of that, so a learning and growth mindset creates accountability for responses to others. So, for example, if people are hearing stories about unfair treatment and discrimination, usually what you might do is start out with lots and lots of studies. And I'll give you an example. So we did some work in a land grant institution in the South, 2 days of training with some faculty members. And when we started out, there was quite a lot of resistance to the idea of racism and racial inequality. And so we kind of brought them along with randomized studies, right? Okay, here's this study here. I gave you a couple here. There's so many. It's not like there's any question that there's evidence. And then the question for people is why, what's your understanding of why these studies, which aren't consistent with your belief system, what's your sense of that? The other thing is that if people say hurtful things, unacceptable, right? So there are rules of respect. So when we talk about growth and learning, we're assuming that the mistakes are from a place of lack of understanding, right? And at least conscious good intentions. We do tend to have a lot of unconscious protective instincts, but conscious good intentions. There is about 10 to 15%, maybe 20% research shows of people who are quite consciously bigoted, who do not believe in equality. They may have something called a social dominance orientation, which is the belief that some people should be in charge and others. And you have them. They're going to be in your classes. They're all around you, right? So then what you're doing is you're just setting up rules for civil discourse. But what I think personally from my work is that we are really powerfully guided by the rules around us. So if we're setting up rules of mutual respect, the rules of mutual respect apply in a growth and learning mindset. So if someone is telling a story of discriminatory treatment, having them be treated disrespectfully, having that story be discounted, that's something that is not acceptable. And needs to be dealt with on that basis. When I think about people who are quite consciously motivated to perpetuate racism or sexism, some of what I'm thinking about is less them, but the other people in the room. The goal there then is to take away their power over the other people in the room as much as possible. Engaging is usually not helpful, and can actually be quite hurtful to others. So a growth and learning mindset needs to be set up first in an atmosphere of psychological safety. Psychological safety is psychological safety for everyone, which means that people who would like to express disrespect and hostility, who want to express discounting or undermining, are creating a psychologically safe and unsafe environment. It's not a genuine point of respect. Let me see if I can come up with some concrete examples for that. So, sometimes in a group of, if you're talking about students, for example, in a group of students, sometimes students will float it, like they'll see, will this float, right? Will this disruptive strategy float? And often other students won't let that float. You know, you don't necessarily need to take a lot of action yourself. You can, the main thing to do is to not exceed it, right? So you may turn from that and say, are there, like, what are other perspectives on this? If it's out and route disrespectful, I usually will say, ouch, that's really hurtful. You know, that's not okay. Everybody in this room deserves to be treated with respect. But I start with ouch. If they hear, if you're arguing as if there's actually a valid point, that's the mistake. If you argue with a level of feeling, like, ouch, that's hurtful, they'd have to then, like, feel okay with saying, oh, it's okay to be hurtful. I'm going to continue on this because it's my right to hurt you or hurt this person. So sometimes people mistake growth and learning mindsets with lack of accountability, or like, I want to be able to be hurtful and cruel, so therefore I should be allowed to because that makes me psychologically safe. That's like a bit of a false logic. I don't know if that helps or not. It's not always easy.
Oh, I think that was wonderful. I actually got a bit of context from the person who wrote that question. They state that they were what they were thinking of exactly. A well-intentioned or ill-intentioned comment in class that was painful for people of color, so students of color. So I think you nailed it. We'd like to do one last question. And we've got quite a few here. So to let everyone know that's still on the call, we will work with Dr. Van Ryn to answer all of the questions that came in that we didn't have time to answer here this evening. And we will post that along with the slides and handouts that have been provided to us.
Sure. But, yeah. So, yeah, it's been a pleasure. I would have loved to meet you, and maybe I'll get to visit and talk with some of you in person. And I know I'll be talking with some of you who are doing research in this area, within a month or so. So I'll really look forward to that.
The last question that we'd like to move to is, what are you learning about bias in your medical students and residents across time, and the effectiveness of learning about strategies to reduce bias?
Yeah. Okay. So good question, right? Like, where's the evidence? I always ask that. It's an excellent question. There's something I want to say about our longitudinal study, and what I would say is that the most powerful impact on bias is norms and role modeling, and that's a challenge. It's a challenge for medical schools because some of the most powerful impact is role modeling from attending physicians in the clinical site. And what's really, interesting is that over time, observations of negative role modeling, and it's usually not like it's just like negative comments about Black patients, negative comments about low-income patients, derogatory, humorous jokes about patients of size. Even with people who are noticing them as not good things, like they're saying, I noticed this, their negative biases are going up. So role modeling, I know this isn't what you asked me, but it's role modeling that's really important. And so some of the question I think that we have as as educators is if we know that harm is being done in clinical sites from negative role modeling, and what's our responsibility, right? And I don't. It's a tough one because we need people to have experiences. What I would say is that faculty training is the first step. So leader and faculty training is as important or more important than training students, because it's the faculty and the leaders who are setting the tone in the environment and are creating an environment that's either okay or not okay, to sort of perpetuate attitudes that are harmful. So what we have done, so this is kind of interesting. So we have like proposals in for randomized studies, and if you guys want to play, to look to see if the interventions that we're doing are having outcomes on patients. What we have done, but it's very hard to get those funded. We have another one going in really soon. So we're doing California Healthcare Foundation gave us funding to do a intervention that is responsive to a new mandated law in California that mandates about implicit bias and reproductive justice training for every single perinatal care provider in California. And the California Healthcare Foundation gave us, Rachel Hardiman is the lead in our group, to develop that training, and that's going to be rolled out soon. So that's like mandated hour-long training. So it's an opportunity there to actually, in a very big way, detect and impact. To see, does this training, if everybody in the organization gets it, does it actually create the kind of culture change and then change in patient care that you might want, that's mutually reinforced. So when we do the training, with like individuals, what we can say is that our training has a few effects. One is it makes people want to know more, to learn more. And the reason we really care about that is that a lot of anti-racism training and interventions have had paradoxical effects, which is actually harmful effects, right? When we do interviews in facilities before we go in, like an organization, we'll try to interview a lot of people. And when we interview the leaders of color and we ask them the concerns, or we'll say we're going to make it worse. That's been their experience. People make things worse for them because they make everybody very uncomfortable without any clear way forward, which is why the psychologically safe work and learning mindset for people who want to learn is so important. So that's the first thing, is our training actually creating a towards thing, like our people want to know more, do they see of benefit? The other thing is, can they apply what we've learned, what we've told them? Can they describe and specific ways that they intend to or will apply what they've learned to their practice? And so we've gotten that. The question you're asking, which is, do we know for sure that what we're doing is creating downstream benefit for patients? We think so, but we need really good studies, and we're trying really hard to get randomized trial studies funded. And I'm fairly optimistic that will happen. These are not easy. Those of you who do NIH research and research, it's not necessarily super easy to get that kind of funding. What we do know, though, is medical schools and residencies that have a positive climate and are doing supportive training on these topics are creating differential outcomes that are more beneficial for their students and trainees in terms of their ability to provide, or the perceived ability anyway, to provide equitable care across patient groups. But as importantly, it's a more positive experience. Some of the training that we've seen, not our training, actually can make medical students less likely and less interested in working with underrepresented minorities, but our training makes people more likely. So, yeah. Your group is doing, you've got people there doing really good work. You should definitely talk to Nicole and that team about the work they're doing. I feel optimistic about that work.
Thank you. That's very kind of you to say. So with that, Dr. Van Ryn, I just really want to thank you for speaking with us tonight. But even more than that, I want to thank you for being a leader in this field, for bringing the scientific rigor to this really important work, and for doing the work in bringing the scholarship and the evidence base and all of the evidence of what you find to medical schools and other health professions. So thank you for coming and speaking with us tonight, and also thank you for generally for the work you do.
You're so kind. Thank you.
You know, I'm a huge fan. And I would also like to thank the participants, especially those of you who stayed just a little bit longer. We will try to find a way to see if we can get the rest of the questions answered. I'm sorry that we ran out of time. And just as a few housekeeping things to wrap things up. So we will have the handouts and the PowerPoint up on the website for the Office of Diversity and Inclusion. If you need CMEs, please contact Jennifer Doherty, who can give you the forms and you can turn them back into her. And if you are on the ODI website, please keep your eye out for future events. We hope to collaborate a little bit more with Dr. Van Ryn in the future. So thank you and have a wonderful evening, and please stay safe, everyone.
Thank you very much, everybody, and thanks for hanging in there. So I'll look forward to your questions, and hopefully I can answer them in a helpful way. So thank you again.
Thank you.